It's my pleasure to introduce Alex Rowe, who's from the CDC, who's going to talk about some fairly complex investigation methods, he tells me. And partly because of that, I think it's probably best to take the presentation first for about 40-45 minutes, and then we'll have questions afterwards rather than interrupt, because there's a tendency maybe to go off into technical detail. So I just want to say thanks very much to you, Alex, for coming up here and presenting this, and over to you for 45 minutes at least.
Okay, excellent. Thank you so much. It's really a pleasure to be speaking with you. My first time here. So I'll be talking about the Healthcare Provider Performance Review, a systematic review of strategies to improve healthcare provider performance in low and middle income countries. And in green, you can see these are near final results, but very much looking forward to your feedback to learn and improve. I'll begin with acknowledging my co-investigators, so Samantha Rowe at CDC, David Peters at Johns Hopkins University, Kathy Holloway at WHO, John Chalker at Management Sciences for Health, although from the UK, and Dennis Ross-Degnan at Harvard Medical School. I'd also like to acknowledge the many people who have worked on this project over the years. A special thanks to investigators who responded to our queries, and generous funding from the Bill and Melinda Gates Foundation, CDC, and the World Bank. Healthcare providers play key roles in delivering health interventions. However, in low and middle income countries, healthcare provider performance is often inadequate. And when I say performance, I mean adherence to some kind of clinical guideline. Many strategies exist to improve performance, and a summary of the evidence would be useful. Existing reviews, however, have limitations. And one of the key limitations is that they focus on a single strategy, when in fact the questions that donors and program people ask in the real world tend to be much broader about how to improve performance. And so with that kind of set of broader questions in mind, we have the Healthcare Provider Performance Review, which is a systematic review designed to help fill this gap. The objective is to conduct a systematic review of all strategies to improve healthcare provider performance and related health outcomes in low and middle income countries and produce the following. First, a database of studies on improving performance for decision makers, donors, researchers, and others. Second, estimates of effectiveness for a wide range of strategies to improve performance and comparisons to identify the most and least effective strategies. Third, focused special analyses on training and supervision to identify factors associated with greater effectiveness, as these are strategies that are used very commonly in the real world. And fourth, the real goal is evidence-based guidance on how to improve performance in these settings. And then finally, a research agenda. And this slide is basically a map of the presentation. I'll focus on the first four objectives. So let's begin with the database. Here are inclusion criteria. So we included any study of the effectiveness of any strategy to improve healthcare provider performance in a lower middle income country on any health topic in any language, published or not. We defined healthcare providers broadly as any facility or community-based health worker, but also included pharmacists, shopkeepers who sell drugs, and health workers in the private sector. We searched 15 electronic databases of published studies, and that was completed in 2006. And we searched document inventories of 30 international organizations for unpublished studies, which was completed in 2008. The eligible study designs are shown here. First, pre-intervention versus post-intervention studies with a comparison group with or without randomization. Second, post-intervention only studies with randomized controls, and interrupted time series with at least 3 data points before and after the intervention. Titles and abstracts from the search were screened, and we performed double independent data abstraction. Queries were often sent to study authors for clarifications and additional details. We defined effect sizes in terms of an absolute percentage point change. The example formula for outcomes expressed as a percentage is shown here in blue. So the effect size is the follow-up value minus the baseline in the intervention group minus follow-up minus baseline among controls, and this is also known as an adjusted risk difference. We calculated effect sizes so that positive values mean improvement, and that's because some outcomes of performance are meant to decrease, so those results need to be flipped around for comparability. Regarding the definition of strategy groups, our goal was to have groups that were neither too specific nor too broad. And the issue here is that if you look closely enough at the different strategies, they're almost all different. And we were afraid that we would end up with basically a line listing of several hundred studies, several hundred strategies, each evaluated by a single study, and we thought that that would simply not be useful. On the other extreme, if the categories were too broad, they simply wouldn't be interpretable. So our approach to kind of be pragmatic and in between these extremes was as follows. We abstracted as much detail as possible on the individual strategy components. And when I say strategy components, imagine a strategy of training plus supervision. That was considered to have two separate components. And we identified well over 100 unique strategy components across the studies. Well, that was far too unmanageable. So we condensed these into 10 component categories. For example, training, supervision, incentives, and so forth. And I would point out that we didn't base these strategy categories on effect size. Rather, we tried to use mechanisms of effect and commonly used labels in the real world. And then we defined strategy groups as unique combinations of these 10 component categories. For example, training by itself, training plus supervision plus incentives, and so forth. Here are the 10 component categories. The first is consumer supports. And the theme here are interventions that are focused on patients or the communities from which they come. For example, community health education or leaflets for patients. Next is strengthening infrastructure. For example, providing a new information system or drugs or equipment. Financing and incentives, for example, changing user fees or financial or non-financial incentives. Institutional approaches, and I do apologize, some of these labels are a little bit cryptic. These include, for example, licensing and accreditation schemes and resource control given to a local government or civil society organization. Group problem solving, for example, continuous quality improvement with or without formal teams. Supervision, which could involve improving routine supervision, but also includes audit and feedback, which we thought was thematically similar. Another bad label here, management techniques that were neither group problem solving nor supervision. For example, health workers' self-assessment or change processes to improve the use of services. And then for training, we knew that we were going to have a lot of studies on training. And so a priori, we divided this into two subgroups, high and low intensity training, with the thought being that high intensity training would be more effective. We defined high intensity training as having a duration greater than 5 days or ongoing training, plus at least one interactive educational method such as role play or interactive sessions. And then low intensity training was anything else. And then finally, printed or electronic information or job aids for healthcare providers that was not an integral part of another component. And the issue here is that virtually all trainings, for example, include the provision of printed materials. And so we didn't feel it was appropriate to split apart the materials there. And so if the printed materials were part of something else, then it wasn't considered a separate strategy. But we had enough studies where it was isolated that it was still a reasonable category to create. Now, before leaving this list, I have to point out that despite our best efforts, high intensity and low intensity training, these definitions did not work at all. There's no difference in the effectiveness according to these definitions. And so for simplicity of presentations, I'll collapse these two. And in a few minutes, I'll talk about some results that suggest what attributes of training are relatively more effective. Okay, defining which results can be compared. So the studies used a very wide variety of outcomes. In fact, in our database, we identified over 1,000 unique outcomes. There's very little standardization in this field. And we felt that it was probably inappropriate to include all of these in the same analysis. So you can imagine including outcomes on mortality and history taking just didn't make sense to include those together. For more of an apples-to-apples comparison, the data are divided into 24 subgroups based on 3 attributes. First, the outcome category, which I'll describe in a moment. Second, the outcome scale, dichotomous or percentage versus continuous outcomes. And third is the healthcare provider type, and there are 2 categories which I'll describe. And the idea is that the results would only be compared within subgroups. So essentially, it's like doing 24 parallel systematic reviews. And this is a very important part of the methodology, so let me show you a picture of this for those of you who are more visually inclined. So on the left-hand side of this slide are our 6 general outcome categories. So we started with over 1,000 outcomes, which was completely unmanageable, and we collapse those down into 6 general categories. The first are facilitators, and again, sorry for some of these cryptic labels, but the idea here is things that we thought that providers needed to have present in order to provide good quality care. For example, the availability of supplies and equipment and that sort of thing. Second are processes of care, and those are the direct actions of the healthcare providers. For example, assessing patients, diagnosis, correct treatment, that sort of thing. The third is health impact, so morbidity and mortality measures. The fourth is utilization or care seeking, which is a patient or client behavior. And then fifth is all the other patient behaviors, which, for example, included adherence to a treatment regimen. And then finally, there were a few outcomes directly related to cost, and we thought that that should be a separate category. So we then subdivided these according to the scale of the outcome. So on the left, you can see outcomes expressed as a percentage, and on the right, continuous outcomes that aren't percentages. For example, a mortality rate or a count. And that's because these 2 different scales have different mathematical qualities, and you can really run into trouble if you try combining them. Within each of these, we further subdivided according to the healthcare provider type. So on the left, you can see all healthcare providers. So that included the main group of studies that included any type of healthcare provider, with the exception of studies that focused only on community health workers. And then the other category, you can imagine, is the community health worker only studies. And that's because community health workers, I'm sure many of you or most all of you know from experience, are kind of categorically different from most other kinds of providers. And this is just as important, the types of strategies you use will be different for community health workers, even if the labels are the same. So training materials can be quite different for community health workers versus nurses, physicians, and so forth. So with this scheme, you see 24 boxes, and these are the 24 different subgroups of data. And I put check marks for the 2 that I'll be focusing on, since in 40 minutes there's no way we could cover all this. And we're still working our way through these 24 sets of data. So I'll focus today on processes of care, expressed as a percentage. Okay, so for the analysis, there's a primary and secondary analysis. So the primary analysis only includes a strategy versus a true control comparison. So it does not include head-to-head studies. And the results are from studies with more than one primary outcome, which was quite common. Those were summarized as the median effect size. So if a study had 3 outcomes, and so 3 effect sizes, we took the median value as a measure of central tendency. Effect sizes were adjusted for differences in effect modifiers, that is, factors that influence effect size regardless of the strategy, and empirically we found 2 in the database. Baseline performance level and public health facility settings, and I'll describe this in a moment. And then the idea is to compare the median effect size distributions of these various strategies. And in this case, we'll start off with medians and interquartile ranges. Okay, let me take a minute to discuss the adjusted effect sizes. I don't always go into this much detail for these presentations, but I know you guys are interested in the methods, so thank you for your patience with this. So I'll take the example of baseline performance. What we found empirically is that for every 10 percentage point increase in baseline, the effect size decreased by about 2 percentage points on average. And so you can think about this in that if you have a very high baseline level, you have less room to improve, you have smaller effect sizes. And you could almost think of this as a disadvantage for a particular study. If you have a high baseline level of performance, it's just harder to get, and sometimes impossible, to get very large effect sizes. And again, this is regardless of strategy. No matter how you cut the data, you always find this relationship. And here's an example of the adjustment. It's very simple. So start with a mean baseline level of 40%, which is typical for these performance, processes of care. So if the baseline for a particular effect size is, say, 50%, so it's 10 percentage points higher than the mean of the entire database, then the adjustment increases that effect size by that 2 percentage points. And so in a sense, it removes that disadvantage based on this particular predictor. And it makes the entire database sort of scaled to the mean of the entire database. And I realize that there are a lot of other ways of thinking about it, but this is, again, we're doing a kind of an overview analysis, and so this is our way of helping to level the playing field somewhat. Next is public health facility setting, and we found empirically that the mean effect size is about 8 percentage points higher than in other settings, regardless of the strategy. So regardless of what you do, if you test it in a public health facility setting, you're on average going to get a higher effect size for whatever reason. Okay, continuing with the primary analysis, for strategies with the greatest effectiveness, we checked for, sorry, another bad label, confounding by setting. This is the best we could come up with, but let me explain what that means. We asked the question, are high effect sizes due to studies coming from settings that were just unusually well suited for that strategy? And I'll show you a pretty vivid example for this in a little bit. And to check for this, what you can do is broaden the strategy definition to include more studies with the same basic strategy and see if the results change. A large decrease indicates bias, and again, I'll show you an example. For secondary analyses, we performed meta-analysis, meta-regression, and network meta-analysis, which includes head-to-head studies, and I'll show you why this can be very important. Okay, moving on to results. We'll begin with the literature search. Over 105,000 citations were screened, and 829 reports were included in the review. 2/3 of the reports were published in scientific journals. The 829 reports corresponded to 491 distinct studies that included 674 comparisons. 2/3, or 448, were strategy versus control group comparisons, and about 1/3, or 226, were head-to-head comparisons, one active strategy pitted against another. So this is really important. This is saying that about 1/3 of the evidence base are head-to-head studies. And in this field, head-to-head studies usually are not analyzed in systematic reviews because of the natural complexity that goes along with that. We could spend the entire hour just on general descriptive studies, but very briefly, the studies were from 79 countries. About half were low-income countries, the other half from middle income. The studies were done in a very wide range of contexts, urban and rural settings, public and private health facilities, as well as community settings. And the studies addressed numerous different health conditions. Regarding the overall risk of bias, this is a categorization scheme at the study level, and we used the risk of bias elements that is used by Cochrane, although this process of combining those elements is still a little bit under development. But just to give you a broad, rough sense of where we are right now, 26%, or just over a quarter, were considered to have a low risk of bias, a little over 1/3 moderate risk of bias, and then 38% in red was a high risk of bias. But you have to be realistic. All of these studies have a risk of bias. I mean, measuring health worker performance is an imperfect science. So, but this tells you a little bit more about study design and how the studies were conducted. Okay, results on cost and cost effectiveness. This will be a disappointingly small part of the results, but here's what we found looking across all 491 studies. There was a wide variety of cost and cost effectiveness data reported, And therefore it was very hard, at least at this point, to do a quantitative synthesis. So just descriptively, we found that 35% of the studies reported on any information on strategy costs or other economic evaluations. 22% reported cost on at least one strategy component. 30% compared strategy costs of 2 or more study groups, and 23% compared strategy costs of 2 or more study groups in terms of a cost ratio, for example, cost per service provided. So in general, the economic information from these studies was often quite thin. Okay, so that was the database. Moving on to the second objective, estimates of the effectiveness of the strategies. And I'll begin with this kind of main group of studies. So it's everything except the community health worker only studies. So we analyzed 171 comparisons from 141 studies and identified 56 unique strategy groups, most of which were tested by 1 or 2 comparisons each. And we felt that at this amount of evidence, the generalizability was really quite uncertain. So we'll focus on results of strategies that have at least 3 comparisons each. And after speaking with other experts, we felt that having at least 3 comparisons was the beginning point where you could start talking about generalizability. So I'll show you the results for these strategies that had at least 3 comparisons each. There are 10 of them, and they're ordered from greatest to least effective. And I'll show you the strategy, the median effect size, and then a little box plot to give you a sense of the variability. And the x-axis on the bottom left is the effect size. Again, as a reminder, it's an absolute percentage point change. So number 10 are printed or electronic information for healthcare providers as the sole strategy. So you can see in parentheses the number of comparisons, and that tells you how much evidence there was. And then in blue, you can see the median of these adjusted median effect sizes, and that's, of course, the center of the rectangular yellow box plot. And then the edges of the rectangle represent the interquartile range. So you can see here the effectiveness is just about 0. Next is supervision only, 6 percentage points. Training only, 7 percentage points. Institutional approaches, other management techniques, plus supervision and training, sorry, it's a mouthful, 8 percentage points. And as a reminder, this, for example, is licensing and accreditation schemes. Consumer supports plus training and supervision, 9 percentage points. And as a reminder, an example of a consumer support is patient education. Consumer supports plus training, 10. Consumer supports plus other management techniques, 11. Group problem solving only, 16. Supervision plus training, 17 percentage points. And group problem solving plus training, 23 percentage points. I want to point out that when I have displayed the number of comparisons, these top 3 have the letters BD, which stand for broaden the definition. And I'd like to show you how we've looked for confounding for these top 3 strategies. So I'll focus just on this first one, because time is limited. So an example of confounding by setting. If you look here in black, you can see the original definition of that top row. It was group problem solving plus low intensity training. There were 3 comparisons, and the median of the adjusted median effect sizes was a very large 60 percentage points. And we were worried maybe there was something unusual about these 3 studies. It's not that they're wrong, but they just might not be generalizable. And so we broadened the definition in the following way. We take the core strategy, which is group problem solving plus training, but now we include any kind of training because we now know that high intensity and low intensity training, that's actually not a helpful distinction. And now we allowed other components to be added. And the thinking is that broadening the definition adds studies, and that should improve the generalizability. And of course, those studies are going to have some extra components. we assumed that the extra components were unlikely to decrease effect size. And the theory all states that, you know, adding more mechanisms by which practices can be changed should help. Now, in the real world, we know that they may not help, but we felt that it was unlikely that they would decrease effectiveness by very much. And in fact, there was no evidence in the review to suggest that adding more actually subtracted, you know, reduced effectiveness. And so we thought that if you add in these studies and the effect size decreases, then this is the likely cause is due to this confounding that I was discussing. So what happens? We went from 3 studies, we broadened the definition, and we found 5 more studies with the same core intervention. And we found that the median effect size dropped from 60 to 23, a very large decrease. So the bottom line is we felt that the adjusted results from these broadened definitions are probably best, probably more generalizable, probably with greater validity, and erring on the side of being conservative. So we are hoping that users of these results would think, well, if I tried replicating a particular strategy, you know, in my setting, what are typical values that I might get for effect sizes? And we felt that 60 was not a good number, and the 23 is probably more reflective of the general evidence. Okay, moving on to secondary analyses. So as a reminder, this is meta-analysis, meta-regression, and network meta-analysis. And the results generally support the primary analysis, which we found reassuring. I do want to say a word, though, about network meta-analysis, and these are more preliminary results, so there's a little caution sign up at the top. Keep that in mind. And as a reminder, this includes the head-to-head studies. So to give you a picture of what we've found, I want to begin by displaying all of the unique strategies, including the control group, which is the green circle in the center. So all of the strategies can be considered as kind of treatments, including the control group, in the sense that, you know, it's still a group to which something, you know, they had been exposed to something. In the control group case, it's nothing, but that's needed for the analysis. And then the strategy versus control comparisons are shown, and so the lines are the comparisons. The green dots are the strategies, and the blue lines are the comparisons between them. And this is usually where systematic reviews stop. And in fact, in this field, this is as far as they go. But now let's take a look at the head-to-head studies by themselves. And you can see there are quite a few. The width of the line is a general indication of how many studies there are. But there's a lot of interlinking here. And you can see some strategies are only brought into the network through these head-to-head studies. And if you put it all together, you get the full network. And so the idea is to use a Bayesian model that draws information from the entire network to estimate all pairwise contrasts within the entire network. So for example, if you look up top, there's no direct study of strategies number 17 versus 19, whatever they are. But this model will give you an estimate of that because all of these strategies are kind of interlinked are connected to each other through the network. Okay, and again, these are preliminary results. This is a fabulously complex network, and the modeling itself is quite complex as well. So there's a lot of work that's need to be done to verify the results, but I wanted to just begin to show you the kind of results that are coming out of this. And what you find is that some additional strategies now deserve attention. And the thinking here is that in the primary analyses, there are these strategies that we kind of ignored because they had fewer than 3 comparisons each. By adding the head-to-head studies, again, we're increasing the amount of evidence by about 50%. There are several new strategies that have at least 3 comparisons. And I'll show you the results for a few of them. These are taken from the top of our list, and all of the following have 95% credible intervals that exclude 0. And so from a credible interval is kind of like a Bayesian equivalent, not quite an equivalent to a confidence interval. So here they are. I won't go into them in any detail, but just take a look at the top one. It's a very heavy intervention. Take a look. Consumer supports plus strengthening infrastructure plus institutional approaches, et cetera, et cetera. But look at the effect size. The mean effect size is 45 percentage points. It's really quite large. So Again, at the bottom, it's very important to keep in mind more work is needed to fully understand these results, and I'm very much looking forward to working with my friend and colleague Hussein here, who will help us navigate these complex waters, but just to give you a flavor of these results. Okay, moving on now to results of studies that only included community health workers, a much smaller group. So we analyzed 10 comparisons from 10 studies and identified 9 unique strategy groups, most of which were tested by 1 or 2 comparisons each. And we found that for the strategy consumer supports plus training, a median effect size of about 27 percentage points, which is fairly respectable. Now shifting gears to answer a different question, the factors associated with the effectiveness of training and supervision. And as a reminder, that's our third objective. So the goal was to identify attributes of more effective training and supervision strategies, with these two analyzed separately. We used a mixed linear regression model with a random intercept, which accounts for the clustering of effect sizes within studies. And the data source was this larger mean group of studies, so not the community health worker only studies, on strategies that, of course, had to include either training or supervision. And again, these are 2 separate analyses, just one set of slides on the methods. The dependent variable were the process of care individual effect sizes, and the independent variables are shown on the bottom. So they're the attributes of training and supervision, which I'll describe in a moment, and then dummy variables that code for the presence of other strategy components. So we'll begin with training. This graphic shows the main hypotheses, so we thought all of them except the last one would be associated with greater effectiveness of training strategies. So increased training duration, an interactive educational method, small group size, having professional trainers, having trainers that were content experts, having at least some of the training on site and some of the training ongoing. And at the bottom, we hypothesized that having a training on multiple topics would be less effective compared to trainings on a single topic. We analyzed 661 effect sizes from 112 comparisons in 99 studies. And on first look, in 5 comparisons, we found a training duration of greater than 20 days. And these were excluded, as they were relatively uncommon, and we thought they probably represented interventions different from typical in-service training in developing countries. For those of you that work in these settings, that would be an unusually long period. And in fact, these longer trainings were probably things like pre-service training, just a different animal. And we also found, unfortunately, that there were substantial numbers of missing values for several of the factors of interest. We spent a lot of time trying to contact authors to get additional data elements, but we weren't always successful. We felt that the validity of the multivariable modeling was questionable because you really started to lose sample size. And so I'll focus just on the univariable results, keeping in mind that these are still adjusted for the other strategy components. This is what we found. The use of clinical practice as an educational method was significantly associated with a 10 percentage point improvement. The use of quote-unquote, 4 quote-unquote key training methods, that is lecture and interactive sessions and role play and clinical practice in combination, was associated with a 19 percentage point improvement. Having some or all training on site was associated with a 7 percentage point improvement. And then finally, increasing training duration improved effectiveness by an average of 2 percentage points per additional day of training when the training covered multiple topics. However, with single topic trainings, longer training duration was not associated with improved effectiveness. Okay, now the same basic analysis for supervision. These are what we studied, all of which we thought would improve the effectiveness of supervision. So standardized checklist, feedback to health workers, increased supervision frequency, financial incentives for supervisors, supervisors involved in a group process for problem solving, and then training and supervision of supervisors. Now it turns out that some of these had very few studies, and so we just couldn't look at them, but I'll show you what we found. We analyzed 165 effect sizes from 35 comparisons and 31 studies. And in 4 comparisons, we found the supervision frequency was greater than 12 visits per year. And these were excluded as they were relatively uncommon, and again, we thought that these represented interventions different from what typical external supervision would be in low and middle income country settings. I think you would probably agree with that. And again, at the bottom, there were a lot of missing values, which really limits our ability to conduct this kind of analysis, but I'll show you what we found. So we found that when the supervision process explicitly included feedback to the providers, that was associated with an 11 percentage point improvement. But none of the other factors were significantly associated. Okay, now trying to pull all of these results together. Evidence-based guidance on improving healthcare provider performance in low and middle income countries. And this is our fourth and the last objective I'll discuss today. So I'll begin with guidance on improving processes of care, because these are the outcomes that I've been discussing. So first, for strategies that don't only involve community health workers, 2 strategies might be good choices. First, group problem solving plus training, and then supervision plus training. Second, for strategies for community health workers only, a good choice might be the combination of consumer supports plus training. To increase the effectiveness of strategies that include training, the following might be beneficial. Using all 4 key training methods, again, as a reminder, lectures and interactive sessions and role-playing and clinical practice. If use of all 4 key training methods is not feasible, at least consider including clinical practice. Increasing training duration for courses on multiple topics and conducting at least some of the training on site. Fourth, to increase the likelihood of higher effect sizes for strategies that include supervision, it might be beneficial to explicitly include the provision of feedback to healthcare providers. Fifth, for strategies that don't only involve community health workers, the provision of printed or electronic materials to providers as a sole strategy is unlikely to change their performance. We're not saying that you shouldn't do this, but if you do it, the evidence suggests that there won't be much change in practice. Moving on now to guidance on monitoring and adaptation. The wide range of effect sizes for most strategies demonstrates the difficulty in predicting how effective a strategy will be in a particular setting. Therefore, it seems prudent to monitor any strategy so program managers can know how well a strategy is working. Monitoring data could be used to better adapt strategies to local conditions with the aim of increasing effectiveness. And it's important to note at the bottom here that this guidance is partly a hypothesis that should be tested, but it's partly supported by the relative effectiveness of group problem-solving strategies, which often include monitoring and adaptation. Limitations. First, and very importantly, are the limitations of the primary studies. There was a lack of detail on strategy and context, lack of standardization, and difficulty in assessing study precision. Second was our overview analysis approach. And keep in mind, this was intentionally designed to identify broad patterns across all studies. So this overview and analytic approach allowed us to see the entire elephant from afar, which is good, but as a result, the results don't reflect some important nuances. For example, all financial strategies are considered equivalent. Clearly, that stretches plausibility. And our vision is that future analyses will be able to drill down into the database and do those more specific analyses to get at those nuances. So I think the overview analytic approach is both a strength, but it's clearly a limitation. Third, with numerous statistical tests, the results represent hypothesis screening, not true hypothesis testing, so take all those p-values with a grain of salt. And then finally, the review is already out of date, although my group is currently in discussions with a donor that's interested in funding an update, so we'll see how that goes. In conclusion, we found an unusually large number of studies on a lot of different strategies, although most were tested by 1 or 2 studies each. Second, there were some very important challenges: heterogeneity of the studies, lack of detail and standardization, and so forth. Third, although the results should be interpreted with some caution because of the review's limitations, the data do suggest greater effectiveness for group problem solving plus training, supervision plus training, training with clinical practice, which was good, or training with all four quote-unquote key educational methods, which seemed perhaps to be better. Also a possible benefit from on-site training and longer courses for training on multiple topics. The data also suggest greater effectiveness for supervision with feedback, and in community health worker only settings, consumer supports plus training. To the best of my knowledge and that of my team, the Healthcare Provider Performance Review is the largest review of strategies to improve performance in low and middle income countries, and we hope that the results help inform decisions by programs and donors, and to help disseminate results and encourage the more specific local analyses I was describing a minute or so ago. The entire database will be made publicly available at the end of this year. Thank you so much for your attention.
Okay, so throw it open for questions. Maybe technical questions first and wider ones after. I had a few questions, so I'll maybe abuse my privilege. So you touched on it a little bit at the end about heterogeneity. So, I mean, it's an incredible amount of information you're trying to distill, and very useful because donors in these countries are obviously getting more interested in performance outcomes and what they can do for it. But the way tell me if I'm wrong, but the way I was kind of thinking about your method was that you're trying to use your definitions of categories, outcomes, and program types to try to control sort of for observable heterogeneity amongst the studies. But there must be an incredible amount of unobservable heterogeneity, which you don't seem to address, but are you thinking of trying to do so?
Yeah, it's a very good question. It's really quite fundamental to the review and its limitations. And what we've done is we've collected a moderate amount of detail on contextual factors and study-related factors. There are probably about 24 of them. So you can imagine, you know, where the studies were done. Was it, you know, rural setting, an urban setting, a high-income country, a low-income country, and so forth. And we quantitatively, and I realize this has limitations, but we quantitatively looked for whether or not those were effect modifiers, and that's one approach, and that's what we've done here. So when I told you about 2 effect modifiers, the baseline performance level and public health facility settings, that's an example of where we've tried to pull in some of this contextual information and use that to help balance out a little bit, help remove some of the confounding. But your comment touches on a much deeper issue, and that is that context, we don't know what elements of context are most important. And even for those that our guts tell us is important, there's no standard way, usually, of measuring these. So it's kind of uncharted territory. And we hope that our very imperfect way of addressing these complexities will sort of stimulate 2 things. First, better thinking on how these things should be measured and how they can be accounted for. And secondly, better reporting of some of these elements, and of course, by releasing the database, we're hoping that people kind of smarter and more creative than us can maybe think about ways of addressing that. Or another thing they can do is simply look for the small subset of studies that apply to their context. That way, they can use exclusion to deal with confounding, if you will, and say, you know what, I'm really just interested in studies on hospitals in sub-Saharan Africa, so I'm going to throw out, you know, several hundred studies and just focus on the ones that mean most to me. But it's a very good question. Thank you.
Other questions? I had one other technical question, just as people are thinking. So you mentioned it in your answer there about the trying to control for some confounding. So the 2%, if I remember correctly, adjustment on the mean or the median, I forget, for the 10% shift in the baseline. Well, I could see how that worked for absolute values, but is there, I mean, what's the difficulties in applying it to the examples you gave on the percentage points? Because if you do a 2% percentage point uplift, it's just normalized across the different, you know, cardinal steps of that percentage scale. So does it really help you any?
Let me see if I follow. Well, firstly, we do it on a much more finely graded. It's a continuous outcome, if you will. So it's not a step of 10 percentage points. We take for any individual effect size, and
right.
The hundreds and hundreds of effect sizes. Each one has a baseline value. Well, we have 6 missing values, but almost all of them. And so we take the difference between that specific effect size and the mean of the entire database, which actually is about 40%.
Right.
And then we apply that it's like negative 0.18 or whatever to the difference between the baseline performance
okay.
level and the mean of the database. So it's not quite a step function.
Right.
It's a little bit more continuous.
Okay.
But it's
an uplift. Yeah.
It's something. And the idea, if you think about it, is to try to create a kind of a normalized context, which is useful if you want to compare things across a wide variety of strategies. But it's also a problem, right? Because it's possible, in fact, maybe even probable, that certain kinds of strategies are designed for settings that have really low baseline levels of performance, and others, a different profile of strategies, are more often applied to the high level baseline performance levels. So it is kind of it is kind of artificial.
Yeah. Okay. All right. When you move to regression, I'm giving them longer to think here. When you move to regression analysis, you applied random effects, but of course you must have thought about fixed effects given the unobserved heterogeneity of the studies. Why did you? Was it presumably it was a conscious decision to go to random effects, and but why?
Right. Well, so it's a mixed model. So we have
right.
the fixed effects
in there. Okay.
In the model,
dummies, right?
And exactly. And
okay.
so we wanted to use the random effect to help deal with the clustering of effect
okay.
sizes within the studies.
All right.
Hi there.
Yeah.
So I noticed that in your selection strategy, you looked at both peer-reviewed and also non-peer. I was wondering just the numbers of that, so how you were avoiding publication bias, because I imagine a lot of what's in the literature is where a strategy has worked.
Yeah. So it turns out that there is a lot of unpublished material that you can get your hands on if you go through enough websites and go through enough dusty boxes. And in fact, about a third of the reports were unpublished, and so that's sort of a good sign. Although Hussein and I were chatting a little bit before my talk, and there are people who will admit that when a strategy doesn't work at all, and they sort of felt that it should have, they may not even put it in a report that goes on the web. So there are two levels of publication in the real world these days. One is, does it even get into a report that appears anywhere?
Mm-hmm.
And then secondly, does it get into the peer-reviewed scientific literature? And so we don't know about what has never appeared anywhere. That's, of course, hard. And then with regards to publication bias, examining that, it turns out that the methods that exist are really best suited when you're studying a single strategy or single intervention. So imagine, I don't know what to call this. This is kind of uncharted territory, so it's a forest of forest plots. So what you need to do is you need to identify the strategies, and we've got, we're proposing one particular way of defining strategies, certainly not the only way. And then what experts have told me is that you look for groups of strategies that have at least 10 replications or 10 comparisons, and then you can begin to use a forest plot or other graphical methods to look for publication bias. But unfortunately, there are very few strategies that have that many comparisons. Really, if you remember that table, there was only a handful. And so I think the publication bias question will be partly unanswerable with what we have. It's a very good question, though.
Derek, did you have a question?
Yes, I had a question. I didn't quite follow. You linked, I think in the first comparison, the number of comparisons within the study to generalizability, and I wasn't quite sure. Didn't really follow the logic.
Oh, sorry. So there were a lot of instances where we had, of our 56 strategies on processes of care, there were, I don't know, probably about 38 that only were tested by one study each. So imagine if you have just some strategy X and it was only studied in one place at one time. It's possible that that might have been the one place where it was just a huge success, or that was the one place where it was a complete disaster. And we felt that if you only had one study, that it would be very hard to talk about generalizability. We thought, what about two? Well, 2 studies is better than one, but you know, that's still, we were a little bit uncertain. And we spoke with the Cochrane people, and they said, starting at around 3 studies, that's when you can start feeling confident. But it's a judgment call, and if some people don't like 3, then you know, we completely approve of and encourage readers to interpret things as they wish. And so that's the nice thing. If you don't like our definitions, you can simply ignore them and apply your own. And there probably is wisdom in doing that some of the time, maybe all the time.
Somebody else down at the bottom. Yeah, Martin.
You showed that beautiful diagram, the network diagram, and you were talking about the head-to-head comparison. So I've got 2 questions really. One is, I mean, it does seem sensible to make use of that. More information is better than less information in that. So 2 related questions. One, I mean, the process you're developing, the Bayesian analysis, how complicated is that? And the second question, which is kind of linked to that, is this is a very beautiful way to do a systematic review and to extract information. How much does it cost to do a study like this?
Okay, so as far as the complexity of doing the analysis, it's simple. I just ask my wife to do it. And then it's simple for her because she picks up the phone and asks Hussein to do it. So it's very simple, actually. A lot of the work has to do, it's sort of like painting a room. It takes a long time to set up, but then the time it takes to actually put on the paint's not so bad. So setting up the data in the right way and getting all the data elements you need, that can really take a long time. But the actual running of the model itself is relatively straightforward. We use WinBugs, which is free, and as long as you have a big enough computer. We couldn't run it at CDC, by the way. We had to, Hussein ran it at Harvard for us as we were running out of time. And we've got a new server network that we think theoretically will help us there. But that running the model itself isn't too difficult. I feel that the real work is going back to the diagram itself and going back to the studies and ground truthing the results, because models that are that complicated obviously can produce just garbage. And so what we've done is we started with the network, which I haven't shown, of the community health worker only studies. It's much, much smaller network, fewer studies, much simpler. And what we've been doing is we've been actually kind of tagging the diagram with the actual empirical results from the studies. And you can begin to tell where the network is perfectly reproducing results from a meta-analysis, which is what you want in unattached or nodes that are only attached through kind of in one place. And then for the head-to-head studies, and this is a little bit of a judgment, is you look at the results of the network meta-analysis and then you compare that to the actual values of the studies, and you sort of think to yourself, and this is a little subjective, is you think, if you were, and you have the sample sizes as well, and you say, well, if I were averaging these out, is this looking about right? Is it moving this high value down a little bit in the way that one would expect, and so forth? And I think it's a kind of qualitative way of ground truthing the model results. So that's something we're doing. So again, the modeling is not the hard part. It's sort of interpreting and being sure that you feel comfortable with these. Because, well, we can talk about network meta-analysis a lot more. But regarding the cost of the review, so if you add together all of the direct funding that we've received, and if you kind of add in kind of, I guess, salary support, because there was a lot of volunteer time up until we got funding from the Gates Foundation, the review is probably so far has costed about $800,000. And it started in 2005 with the protocol. We did the literature search in 2006. It took 3 years to do the literature search, screening those 100,000, 105,000 citations. Getting the, actually finding the materials was sometimes pretty labor intensive. The data abstraction process was unbelievable. We had a 20-page data abstraction form, and sometimes before we had funding, it was just volunteers really kind of working on this, some grad students, sometimes us. that was a very labor-intensive process. Following up with the study with the authors, we had an entire protocol just dedicated to finding and talking to and getting. We had to get signed agreements from every single time they provided us useful information. We had to put all of that into kind of a correspondence and say, do you agree that this is what we can use? Because sometimes they were telling us things that were different than in the reports. And my favorite example is this wonderful study on epilepsy. There are not a lot of studies on that. And there was one nice result that was in the abstract and the results and the discussion, and we couldn't figure out where the number came from. And so I was abstracting that study, and so I started with the Research Institute in Africa and slowly found that he was working in a neurology clinic in Tennessee. So I finally got a hold of him, and I said, we found your study. It's really interesting, but we had this one question. And I explained what it was. It was all over email. And it took weeks to find the guy, by the way. And he said, I'm so glad you like my study. And everyone's always surprised that you found my study. Well, that's great. And we said we couldn't understand where this one result came from. He said, well, I will contact the analysts who worked on this. And we found out that it was a mistake. And so in some ways, the database has more than what's in the actual studies because we've gone to such lengths to try to untangle contradictions and get additional data elements. So yeah, it's been a huge, long road, but hopefully useful somehow.
You see.
Can you say a bit more about what you plan to do with the database once it's made public, and what's kind of the timeline for the next phase of the research activities?
Excellent, thank you. So what we're at this point, kind of one purpose, a main purpose of this trip through Europe, going to a couple of cities, is to present the results. I want people to tell me all the criticisms, all their questions, and we'll try to take that into account as we finalize the analysis. That's why I'm highlighting the fact that this is near final, which means, the window is still open if you have good, there are comments that we can use to improve things. But we'd like to begin working on finalizing some of these overview analyses over the next month or two. We'd like to ideally, this is my wish, to have a peer-reviewed publication timed with the Cape Town Symposium on Health Systems Research, which will be at the end of September. And we'll have a satellite meeting there for any of you who might come. It's open to anyone, where we'll spend about an hour or so getting into the results, as I've shared here. But then we'll have about another hour and a half to play with the database. And so we'd like to time the release of the database with that symposium. And the idea is that we'll have documentation so you know what all the variables are. And I think this beta version release kind of in September will be not all the variables, but we think enough so that people can find the subset of studies that they want. They can get information on contextual factors and, of course, the effect sizes. And we'll probably have a version of the database that's not so digested and some that's more digested. So if the more kind of people wearing their research hats want to get into the guts of it, they can. And those people who kind of, are happy with some of our assumptions and just want to work with it kind of at that level can do so. And we will, as much as we can, work with people who want to do analyses with the database. And we want people to use it, whether it's program staff that are just interested in, what are all the studies from Ghana or wherever, that's fine. And then other people might want to do much more in-depth analyses, and that's wonderful as well. And then you can see we've got quite an agenda of things. We have to fill up that 24, that box there, all those 24 database or subsets. And we'll go through that and kind of crank through the analyses, probably getting into 2015. And then in the next couple of months regarding updating, we'll be negotiating with the donor to see if they want to update a review, fund an update, of the review. And then we'd like to ideally do that kind of over the next couple of years. And what our vision is at the end of that period, rather than having a system that we don't like so much, where we don't do anything for a few years and then have a spasm of data collection and update, what we'd like to do is transplant the entire project to a developing country center of excellence on systematic reviews. And right now, there are several partners that are helping to build capacity in about a half a dozen places in low and middle income countries. And we think maybe 4 or 5 years from now, we could take everything that we have and kind of give that to a group along with funding to help support their work. And then they could have, our vision is a small team that continuously does an update and continuously, releases, updates a publicly available database for use for everyone. So that's kind of our vision.
As well as making the data available, have you considered making the protocol available so that people can feed in to the database as well on a voluntary basis? Or
Yeah, I think that would be an interesting. A few people have suggested that. Yeah, that's something that we're definitely thinking of, and we also plan on putting working with other colleagues in this field to think about what kinds of guidance we might have for future studies of quality improvement to maybe improve the kinds of data elements that are reported to improve the quality of studies in the future. That would be nice as well.
okay.
That might be an opportunity to get some of the results that aren't published. So if people can submit the protocol, if they could do that also with things that maybe don't make it in a report because it encourages the publication of non-results.
Final question? Well, my last question is, where's the acronym?
Oh, yeah, well.
Well, you have to have an acronym to sell it,
Yeah, we worked on that for a while, and we were too
Nothing
tired.
happened. Okay, so we need an acronym for this guy.
Yeah. I'm definitely open for that.
There's a website that gives you acronyms when you put in the title of your projects.
Really?
Very good.
There you go.
Does the website have a good acronym?
I don't think so. It's acronym.com.
Oh, there you go.
Yeah,
All right,
yeah.
very good.
Okay, on that note, then, thanks very much,
Thank
Alex.
you
and
very
hope
much. I really
keeps
appreciate
going.
it. It's a pleasure.
Right, thank you.